Prostate cancer is one of the commonest cancers that there is, and of course is a huge cause of both death and morbidity in men. The focus of what we've been discussing this afternoon has been on the drug treatment of prostate cancer. Obviously there is a lot of interesting development in the surgical and radiotherapy approaches, but we were focusing on the systemic treatments. The first systemic therapy ever to show survival advantage in prostate cancer was only found to give such an advantage in 2004. That was docetaxel. So actually the whole area of oncology drugs in prostate cancer is a relatively new thing. But of course, since then, and particularly in this decade, we've developed several new drugs which have activity primarily proven in patients where the cancer has become resistant to hormone treatment. So those drugs include Abiraterone, enzalutamide, cabazitaxel, and a radiopharmaceutical called radium-223. And all of these drugs have shown survival advantages in addition to docetaxel among men who have become resistant to first-line hormone therapy. Now, the most exciting developments in the last couple of years have actually been more to do with the sequencing and the way we give these drugs rather than new drugs. And the focus of a lot of what I was talking about today has been on the results of the trials which have been addressing the question particularly around two of these drugs, docetaxel and abiraterone, and about whether if we give those drugs early at the point of diagnosis rather than waiting for initial treatment to fail, do we get extra benefit? So we've known for a couple of years now that docetaxel can bring quite significant survival benefits if you give it as a first-line treatment for men with metastatic disease at the point of diagnosis. There's a lot less certainty about patients with non-metastatic disease, although we know a lot of those men will still go on to die and suffer from prostate cancer. The more recent results we've heard this year have been around using abiraterone in that context, and they show, in my view, really large clinical benefits in terms of improving overall survival. Now, there are essentially two trials there. There's the STAMPEDE trial, which is a UK-run investigator-sponsored trial, and that looked at men both with metastatic disease, but also high-risk localized disease, and showed a very significant survival advantage there. About 37% reduction in the risk of death in the whole group. There was also a commercially sponsored trial called LATITUDE, which is about abiraterone in particularly high-risk metastatic patients, and that was similarly positive. The two questions that now remain are firstly, how do we get access to these high-cost drugs for this very large segment of the population, and at the moment that's something which is really exercising us quite a lot. And the second thing, of course, is, well, the trials that showed that docetaxel worked in that setting were done separately, and so the question is, should we choose abiraterone or should we choose docetaxel for those patients? We have a little bit of information on that because the STAMPEDE trial did, as a sort of byproduct, have a short period of time when it was randomizing between both treatments. So I showed some data today which were recently shown at the ESMO meeting, comparing head-to-head, not in a statistically powered fashion, the comparison between immediate use of docetaxel versus immediate use of abiraterone. And in fact there, the answer is not entirely clear-cut. It looks like there's no obvious discernible survival difference between the two treatments. There may be some differences in the time to PSA progression, but that might be explained by the different mechanisms of the drugs. So there I think the jury is still out. At the end, briefly touched upon new developments in prostate cancer. Particularly there's a group of patients who do not have metastatic disease, but where they are already resistant to first-line hormone treatments, the so-called M0 population, and we're expecting results from trials next year exploring actually for 3 trials looking at the new generation and next generation of hormone receptor antagonists. We'll see what those show, but if they work in later stages of the disease, it's highly likely those trials will be positive. And of course, there's been an increased interest now in the immunotherapy drugs, which of course are the talk of the steamy in all sorts of cancers. Actually, immunotherapy's not been that successful in prostate cancer until recently, but we did just briefly touch on some recent data suggest that some patients, probably just a small proportion of patients, may get a dramatic benefit from immunotherapy. So I think we're going to see more about that in the coming year or two as well.